well. LLMs are so powerful, right? They do things extremely well. They summarize stuff. They can translate things really well. They are masters at language. And they're also really great at brainstorming. It's generative, right? It can say, what are all the random things that could possibly be going on? Where they are weak today is facts and why. How, if you say why to something, if you say, help me brainstorm or help me copy edit this, like, great. You say, why is that the case? It's just going to do its best guess to fill in. So in certain contexts, that doesn't matter. But in contexts where there's usually a lot of information asymmetry, like in law or in healthcare, like guessing can be really dangerous. And
Could be
so
fatal.
could be fatal.
Yeah.
Welcome to the Counterweight Podcast. I am Doug Rogers, your host, and I'm excited to share these stories of vision, passion, and growth leadership in digital health. I am focused on speaking to and learning from founders, growth, and operational leaders across the healthcare space about their journeys and lessons learned. We believe that a majority of people join healthcare companies, technology companies, providers, healthcare systems, because they believe in the mission of improving lives of those around them. We will discuss with our guests their why for digital health. We will learn about success and challenges and what they learned from these events for themselves and for their teams. We will also discuss what tips and tricks these leaders use to help keep them positioned for success, as well as how they balance the tension between mission and margin. Join us each week for a new episode with our guests. You can find us on Apple Podcasts, Spotify, YouTube, and LinkedIn under the name The Counterweight. Subscribe, like, follow, and give us feedback as we go along. Now on to our show.
Hello and welcome to the Counterweight. My name is Doug Rogers and I'm joined by my co-host Russell Stover. And we are very, very pleased on what may be the snowiest day for her. I don't know, Chicago. She's in Chicago, so they've already had a lot of snow. It's not snowy for everyone, so if you're listening to this, just know she's having a winter escapade. But we are extremely pleased to welcome Erika Warren to the pod. Timely, a lot of things in the news. Super exciting what they're building, and I'm not gonna bury the lead here, Erika. I'm gonna turn it over to you. Introduce yourself and Insightful Med, and then I think we've got some super fun questions to dive into, and I'm looking forward.
Thank you so much for having me and inviting me here, Doug and Russell. As you already said and covered, my name is Erika. I'm the co-founder and CEO at Insightful. Build academic research tools for librarians and researchers, as well as now a tool called Insightful Med, which is specifically focused on health, and it's made for patients and caregivers and their problems.
That is awesome. So I know Russell and we've got a number of questions. In fact, I love because you actually teed up a question I want to ask a little bit later when you said building for academics and researchers. I hadn't really pulled on that thread when I was looking at your website. But before we even get there, we were talking before we started the recording. You do not have a traditional healthcare background. I think that's fair to say.
Yep.
What brought you here and why? Why one of the hardest, most fun, but one of the hardest spaces to tackle? Why are you doing what you're doing?
From my experience so far, you're here in healthcare either from a personal story, which is our case, or this is where you've been for your whole career. So as you pointed out, I do not have a healthcare background. I've spent my career in tech and startups and primarily building consumer facing stuff, really around information tools, education tools. The thing that really gets me out of bed is thinking about how to build equity across industry. And so I've just sort of followed a career in how do I help and build for the little guy. And in healthcare, unfortunately, that has turned into patients. So how we got here is a little bit serendipitous. My co-founder, Mike Wizoon, and I used to work together at another education company. And he's one of those people who's just constantly building. He's always tinkering. He's an engineer. And he had built a librarian academic literature discovery tool just because he wanted to.
Why not?
His wife is an academic. And so he was, familiar with some of the problems that people doing research in sort of niche areas, how hard it is to connect with other people and how to find other research. And so he, again, was just building. And he created this tool that got picked up and used by librarians and academics. It wasn't specific to medicine, it was all of academia. And it just sort of took off with this niche cult following within that audience. And a lot of those people across the world don't have the same sort of resources and tools that we have in the US, and particularly in different funding models. So we started there, and then somebody in Mike's family got sick. They showed up and couldn't figure out what was going on. They were asking lots of questions. Doctors didn't have a lot of answers, running lots of tests, collecting lots of data, and, was stable enough to go home and said, come back in 6 months. We'll just do a follow up. And if you have ever been in this situation, or your family member, a loved one has been in this situation, that is like not a satisfying answer. It's sort of almost unacceptable. It's understood, but no one just sits at home and says, like, I didn't feel well. Things were really bad. We were in the hospital and now we're just going to wait. Mike used the research and academic tool that he had built to go out and do a scan of literature and papers that might be able to have some information and help with what was going on, just try to help them understand. This is common. People use Google, they use ChatGPT now. This is not a new niche problem. But what he had was something that was rooted in science and data and literature, and it worked. He found a paper that showed that the things that were going on with his family member, all the symptoms, all the actual hard data from the medical file pointed towards a diagnosis that was missed by the care team. So an appointment at the Mayo Clinic later, they had a cancer diagnosis.
Wow.
And sitting 6 months later, nothing good comes from that. Not a better outcome for the patient, not a cheaper care model, potentially liability, right? There's nothing that wins in that. And so from there, he sort of called me and said, I know that, you like to solve information asymmetry problems and you like to do this. I think the root of what I have based in science, could really help patients and families learn more about what's going on and help them advocate for themselves and just educate themselves. And so that's how and sort of why we got here. That message resonated with me too. I'm a caregiver. I help my parents. I help take care of my own family. And until you're in that situation, you know how much you just feel out of control and grasping at any sort of information that you can get. And accuracy and credibility matter so much. And so I really resonated with the ability of wanting to help people help themselves.
Wow, what a powerful story. And I think we all identify, right? I mean, with this, I think you said it well, Erica, feeling out of control and information asymmetry. And I can't think of a space where there's more information asymmetry than healthcare. Um, and just an incredible thing to tackle without a doubt. Guide us a little bit. So talk a little bit about Insightful Med. You are insightful. So you mentioned it started and still is providing a service for librarians and academics. It expanded. You now have the ability to provide a tool for patients, for caregivers, and for providers. For the product, for the business itself, what is your biggest focus? Is it equally on either side of the equation, or is one, as the business continues to evolve, is it one more so than the other?
We are primarily focused on patients and caregivers. The library tool is something that we give away for free to librarians and academic researchers. And that's really the base technology that powers Insightful Med. Insightful Med takes that concept and says, okay, well, it's not good enough to just be able to find more papers. You need to understand them. You don't have a PhD or a medical degree. You need to be able to find the right ones. You need to be able to verify the information that's in them. You need to be able to connect it to your records. You need to be able to know what to do next with this information. And so within Insightful Med, we are really focused on the problem that's how do you build patient empowerment and collaboration into health, moving away from a more paternalistic relationship into something that is more co-produced between patients and care teams so that they get better outcomes, like I mentioned, and that are, sort of first use case. I personally think that patients are underappreciated and underutilized in their managing healthcare and in their own care, and that if we can treat them like partners with the right guardrails, uh, we may even not only help them have a better experience for their own health, but solve some of the other additional issues that are plaguing the US health system at large.
Yeah, absolutely.
Yeah. So, and it's interesting. I think, um, i the story of how Eric and I got connected is kind of funny.
Yeah.
So I don't know if you guys talked about that before on the pre-show, but I think, for our viewers, Eric, I was a Heart of Healthcare podcast, and Haley was interviewing I one of the original founders of Open Evidence, and she had specifically brought up, and I think this post that she did actually went viral,
Mhm.
at least on their terms. She had brought up the fact that she felt that it was important that Open Evidence provide the same service that we're providing to doctors to patients, or that that service exists. And I think I had mentioned that, and then I think I jokingly created a change.org petition, right? And Erica had reached out and said, "Hey, I used to
Not know
work
this.
there, but look at what we've built here." So, I
That was
we
a real full circle moment for me. I was like, I do not want this petition to win, but I work so hard to make petitions win.
yeah,
So it's like, don't
yeah.
worry, Russell, we got you covered.
I'd have to go look. I think it has like 6 or 7 votes right now because nobody cares anymore because of
Yeah.
what's happened
All
in
the
the
things
past
that are
week and a half.
happening.
And again, I'll time date us right here because things seem to be moving quickly right now. It's Friday, January 16th at 2:25 p.m. Central Time. But things have changed. I guess the world has changed quite a bit since then. And there are some other players in the market now.
Mhm.
But I felt, I think going back to that original conversation that we had, I think that if I remember the principled argument that was made by the gentleman from Open Evidence, it was that essentially Open Evidence didn't want to do this because their primary target ideal customer was physicians, and physicians were kind of guarded about this. And the idea of patients potentially being subject to bad information or not understanding what they were reading because they were doing this research on their own
Mhm.
was something that Open Evidence probably still is concerned about, and that we know providers are concerned about. And by the way, I love doctors. I think what they do is amazing, and the amount of effort that they go through
Totally.
to actually become physicians is incredible. But this is a conversation that needs to be had because it's important that we find a way for patients to be educated and be a part of their own health process in a deeper way. And I think that the way that you guys are approaching it is different than a lot of others. I guess the question that I kind of been wondering about for a while is, how do you feel about, why is it important for patients to be empowered? What does that bring?
As we were talking about earlier, if I'm the patient, this is my life. This is my agency, and I'm just on the sidelines now. Like, I have a ton of data and all of control. Like, I don't go to the doctor and you like give me health. Like, health comes from what I do. Do I take my medicine? Do I pay attention to symptoms? Am I healthy? Am I eating? Am I exercising? I do all these things. So to think that like we can have one without patients being a big part of the mix and bringing different but equally valuable information to the table is just sort of, I think, is outdated. It's an outdated way to think about it. And luckily now with a lot of, I think the concerns are real. Like, we've heard them. We've explored this market from a lot of different angles, from both serving providers to hospital systems, and we can get into that. So I'm not discounting sort of the concerns that you mentioned and that Open Evidence had heard too, and the technology that exists today that didn't 2 years ago really closes a lot of these gaps. And with appropriate guardrails on the information and where it's coming from and the sourcing and transparency and credibility, I think we can overcome a lot of those concerns to make sure that patients aren't turning into doctors. Like, that's not the goal. And they're incredibly busy. I don't know how much you know about how information, new science and information and breakthroughs get disseminated into the healthcare system, but it is slow, like
So slow.
decades slow. And if it's me or you and your kid, I don't want to think that my doctor doesn't know the latest stuff because they're reliant on push marketing like emails and conferences and journals. Like the information system within healthcare and how patients or how doctors and staff learn is also fundamentally broken. And I hope that open evidence like goes and crushes that problem. Because right now they have a huge market share, but it's still all recall. How do you learn something that you don't know? How do you know what you don't know? Right now, you have to go to a tool, ask a question, put in information. Like that's basically saying, like, I think I knew that there was an answer, but I don't remember. That doesn't help you learn something you don't know anything about. And so, like, there's still this gap in terms of quality and new science and new protocols that like we need to solve. And no one will care more about their individual outcomes and health than the patient. So why not have them help? Like, why not put them in? Like I say this all the time. It's like, I'm going to Google regardless of what you tell me. We know that. No patient's going to just listen and say, like, you got it, doc. I won't look up anything anywhere. Like, it doesn't work. We know that. So why don't we turn that engagement into something productive? And, I think that's where there's a lot of opportunity and why it's so important. You can shortcut we've heard from people that have used our site, like they find mistakes, they shortcut their time to care, they like determine that they maybe need to see somebody else. Like they're doing things to help them advocate to get better outcomes, not just necessarily system outcomes. And that is why it's so important and powerful.
So we'll drop a link when we publish the episode to the reference here. But I think Erica, I saw on your site, and we've used this stat before in a former life that it takes approximately 17 years for evidence to go from being published to widely being in distribution. Oh, by the way, Russell, you'll remember this. In a former life, we were in the pop health space at a technology company here in Kansas City. Will remain nameless, but our faithful listeners, they know who we're talking about. That was one of I sold this technology, and that was one of our favorite things that we would talk about is we would go to a health system and say it would take 17 years for the latest, greatest to get to your fingertips, and we're going to put it at your fingertips today. And this was, 10 years before any of this fantastical technology that we have right now. Let's for a moment.
I mean, just for reference, the iPhone is 18 years old. So if
Isn't that
you
crazy?
can remember, like if you're walking into the room and you're like, the information my doctor may have is like either based on when they graduated from med school, so or like
Yeah.
finished with residency. So if you got a young doctor, their knowledge is more recent, or 10 to 17 years late. And that's a blanket statement. Obviously,
Crazy.
people follow things, but like, what? Okay, I know what I'm focusing on now. The last 17 years of science, right?
That's right.
That's information asymmetry right there.
Yeah.
Yeah, 100%. It's in the system that doctors rely on and also with patients. It's like a double asymmetry. And I mean, like I said, we initially started trying to figure out if we could solve that for doctors because I too love doctors. Like I want great healthcare. And I'm not one, right? So how do I help them have it? It's a long story. It's not a long story, but the things that we heard get pointed to the incentives within the system that make trying to solve that problem not the highest priority. And so we said, screw it, we're going to solve it a different way. And that's using patients.
Which we talked about earlier, the consumer.
Hmm.
We sometimes use consumer and patient interchangeably, and sometimes we're intentional about saying consumer to differentiate from when you're a patient. But in this case, let's use it interchangeably. The consumer is having a day in
Yeah.
healthcare. More cost is put on them. Premiums are rising. 24 million people are impacted by the ACA subsidies going away. 4 million of those most likely will not either have chosen not to sign up for coverage or will cancel their coverage because of the cost. Medicaid is most likely going to move another 10 million people because of the work requirements and eligibility reporting over the next 12 to 18 months. So you're going to have a group of people that have limited to no insurance, which really means that they're going to be a much more active consumer of healthcare resources out of necessity. And Erica, I think, tools like what you are building and others is going to be in the spotlight to help me navigate and figure out all of this stuff that before I was just, hey, I've got insurance, I'm going to go see my doctor and they'll tell me what to go do. For a moment, just let's take a sidetrack for what y'all have built and are building. I presume, but I don't want to presume, so I'll ask the question, is this all based off a large language model? Is that how you get and present this information to the patient in the way that is interactive, or is there a different approach that you're taking at Insight?
Yeah, it's a great question. Thank you for asking it. We use LLMs at the proprietary library science, how you find
Yeah,
the the literature that connects to your records is not an LLM. It's not AI. I want, if you allow me to
yeah,
elaborate a little bit here, one of the things that I've learned is that nobody understands, few people understand how any of this stuff works. And so half of my job is not only like health literacy, but tech literacy, because that'll help you. And maybe this is just my bias again. See, here we are trying to try to help people understand the tools that they're using. But first of all, like AI is a vast, vast, vast term, right? Like it's everything from social media algorithms to fraud detection to ChatGPT or whatever your LLM of choice is. So usually when people say AI, they're talking about generative AI, which is a subcategory. And generative AI are things like LLMs. They study and use a tremendous amount of data to learn and then create original, I'll say with in
parentheses. Yeah,
parentheses, right, in quotes, original content, whether in large language models are focused on text, language outputs. There are other Gen AI models that, focus on everything else, music, video, photos, all the stuff. And the way that LLMs work, right, is you can think of them, this is a simplistic definition, but you can think of them like a autocomplete. They go out and they train on pretty much all of the information that's accessible on the internet, a bunch of copyrighted material, legally pirated books, a lot of open access medicine, you name it. If they can get their hands on it, it trains on it. And what they're doing is building a map, a language map, like how words are related to one another when they show up by other words in what scenarios and what context. So the example that I always use is like if you put in good, the next word could be day, by, morning, job, right? Like the context around where good, with the next word to follow good is dependent on the context. And so these maps map all of that. It's math. It creates a probability model that then, depending on what you put into it, it takes its best guess as to what the output should be. And it takes in all that context and just keeps running over and over again. So that's where it's like the autocomplete component is. It's also where hallucinations and stuff come in. People view that as like a bug, but it's fundamentally part of how probability and math works. And so it's inherent to these LLMs. So why the heck am I telling you all that? Well, LLMs are so powerful, right? They do things extremely well. They summarize stuff. They can translate things really well. They are masters at language. And they're also really great at brainstorming. It's generative, right? It can say, what are all the random things that could possibly be going on? Where they are weak today is facts and why. How, if you say why to something, if you say, help me brainstorm or help me copy edit this, like, great. You say, why is that the case? It's just going to do its best guess to fill in. So in certain contexts, that doesn't matter. But in contexts where there's usually a lot of information asymmetry, like in law or in healthcare, like guessing can be really dangerous. And
could be
so
fatal.
could be fatal. And coupled with, if you aren't a savvy audience, how will you know that it's not right? Right?
And it,
Like you don't have the transparency to follow where this thing came from. And so the way that Insightful Med works is we leverage LLMs for their strengths, for brainstorming. Given the symptoms, what are all the possible things it could be, even the 1 in a million cases, and summarization. Help me explain all this really dense academic literature to a 12th grade reading level or in a different language, whatnot. And then the research piece, though, the fact generation and the why, we use our machine learning. It's a network graph that's uses a bunch of algorithms and is based off of citation metadata and papers, which within academia, that's sort of the gold standard, how papers are related and authors and research topics. And so we use LLMs on bookends to their strengths and then fill in where they're weakest in the areas for medicine, for example, where it's really, really important. So everything within Insightful Med, every single statement is cited either to your record, if you chose to share a medical record, or to the science. And we cite it, we show you the exact excerpt that it was pulled from, so you can actually verify, or your doctor can verify, and we give you the link out to the actual publication. So it's full transparency. I like to say, we give you the receipts, right?
Yeah.
And it's also helpful to care teams, right? So it's not great. I've educated myself and I can go advocate and I can be a bossy mom and get my way, right? If it's coming to my kid. But what a waste. It's much easier to be able to say, hey, I think it's this because of this and this, you have a site and a source to then share with your doctor, which they're pretty receptive to, rather than, oh, I asked this on ChatGPT.
So that's a really great explanation. And you can feel this when you use Insightful Med, which I have. And I honestly, I really appreciate it because you can it takes you right to a piece of literature and it summarizes it in a way that's easy to understand. And then it also allows you to kind of dig into it if you want to learn more about what that actually is telling you. So it's useful and it allows you to be able to take that to a physician whenever you're done. Something that I want to ask you though is, I think there's a couple of different things I'm interested in here. One is your perspective on, there, Dr. Google, as it was called, Google is powered by, and the business model for Google is based on advertisements.
Mm-hmm.
It's a great business model.
Yeah.
But there's
so
this
does
thing,
open evidences, by the way.
Yeah.
Just,
Yeah.
yes.
Right.
And
you have
it's
an
also
$8 billion valuation off of pharmaceutical advertising to doctors.
And it's also OpenAI, who's just launched a consumer product and presumably Anthropic's, but we don't know a lot about that yet.
Mm-hmm.
But what happens with this is there's something called search engine optimization. And ultimately, the advertisements combined with search engine optimization ultimately influence what the search engine returns. And we also know that with ChatGPT, it's influenced because it wants to bring you back. It's heavily influenced by impressing you and keeping you happy. So there's problems here, right? And what I think what search engine optimization led, at least in part to, along with social media, was snake oil sales. That's something that I keep using that term because I think it's an important one. And I used it on our last podcast.
Mm-hmm.
But I guess my question to you is, how do you feel about that? And how does Insightful Med view that particular challenge that exists?
Yeah, you're talking about the financial incentives behind any product, which again, from a tech literacy perspective is so important to ask. Who is the person paying for this and benefiting from it, right? So this is what you go even back further than Google, Dr. Google. This is what did WebMD, and they tried to solve this in the 90s, and then on an ad-based model, which led to more clicks, and the answer of oh, well, what leads to more clicks? Well, thinking that you might be dying, less personalized generic information. So I have to click to the next page and then the next page and then the next page. And, eventually they sold to pharmaceutical companies, which, are then using it for their means. And they're not bad means. It's just a question that you need to be aware of. And so I worry about it, frankly, a little bit more on the open evidence side, because I feel as a human. I've seen this before. Like for people to say like, "Oh, I'm not influenced by advertising." Well, like trillions of dollars are, and history has sort of proven them that's not true. And so what happens when doctors are seeing this advertising that they can't pay their way out of right now? Hopefully they move to like a paid model and hospitals buy it and we can get rid of some of that. But like I worry about the incentive and the risk and the bias that introduces to judgment, not necessarily in the tool, but the implicit decisions that happen behind it. And you can say the same on the patient side. Our approach right now, we give the tool away for free because we don't use LLMs for this whole process and really the chunk of it. It's actually not super expensive to run until we're at real scale. And our approach has always been to monetization has either been charge patients directly once we figure out how much it actually costs and how much they actually need, because again, we're not trying to capture eyeballs. We're trying to help you move on. You're dealing with something serious. Like the last thing you need to be is glued to your phone. Like you should be focused on other things. So our path is to focus on serving the patient needs. And if we build a tool that does that better than anything else and is trustworthy, we believe that people will pay for it. And or if they won't, we can go a foundation model similar to Wikipedia, where or change.org is another place where my background comes in, where a little bit supports the masses, and a lot of different fundraising opportunities open up to that. But one of the things that about our company that I really didn't highlight on is like we are intentionally not raising venture capital,
Yeah.
and we want to both control our destiny, and we know that patients are not where the money comes. I mean, it's kind of ironic because it's where all of the money in healthcare comes from, but it's not the revenue generating billion-dollar companies. That's not where that money comes from in healthcare today. And because of that, we're in this mess. We're in this mess where patient priorities aren't focused on. And so I happen to think, and my experience in consumer shows me that if you build a product, consumers are fickle. You have to build something that they really value, and they value transparency, they value choice and control, and they value personalization. And I think many of the tools, ChatGPT and Anthropic included, are helping chip away at this massive wall and make all of those things better. The question is it enough? That's where the competition comes in. And that's where, at the end of the day, patients and consumers win, regardless of who the behemoth is or how many solutions there are.
So you've got right now you've got I'd say unique go to market, and I'm not trying to put words in your mouth, so guide me.
Yeah.
But it sounds like you're in a discovery phase in terms of both what the market will accept and what's right for insightful in terms of the financial model, who you charge, like who actually bears the cost of the service. What are are you and your co-founder, are y'all bootstrapping this? How do you think about the funding mechanism until you hit scale, if you will, for your organization?
Yes. Are self-funded, bootstrapping. We've had, it's funny, we have people say like, when are you going to charge for this? Like, I want to pay for it. Like,
Yeah,
when can you charge for this? I want to, share it
yeah.
with my patient advocacy, um, non-for-profits, patient advocacy groups will ask us that all the time. Like, can we charge for this? And, um, we'd be like lead gen for you. We want to share with all our patients and we think they'd love it. So we're in discovery and sort of like punting on some of that for a short term. But we also have, I think, some more than anecdotal, but some evidence that that's not the primary barrier right now that like we need to tackle. We need to grow and like reach patient. I mean, the thing that it limits us on, honestly, is marketing. Like we're not, we've grown entirely organically through word of mouth and referral because we don't want to spend our money, or we don't have a lot of money to spend on marketing. And so part of our challenge is figuring out how to fund the growth that's necessary in consumer without revenue.
And I mean, that's a huge challenge, right? I mean,
Yeah,
how do you
totally.
put yourself in front of 300 million eyeballs in the US, 350 million eyeballs in the US, and, 6 billion, however many people globally? that could use this. I'm curious, Erica. So as I listen to both the mission, vision for Insightful, I mean, one, it just resonates with me. I mean, I think, as Russell talked about, this concept of trust and transparency are very real, both needed things and impactful things, especially in the healthcare space where there is such an asymmetry. And you touched on this, Russell called attention to this. We just had ChatGPT launch for health, which is going directly to the consumer. Claude's doing the same thing. I guarantee you Google will do the same thing. You're going to see any number of the big models, et cetera, but they don't necessarily create an element of transparency. They're
Right.
going to create an element of engagement.
Correct.
Um, I think there's a tremendous opportunity for something like Insightful to be that bridge between the consumer and provider and create a more trusted relationship and make them truly partners in their healthcare process, not just ships passing in the night that happen to meet at an appointment
Yep.
and then you give information.
Totally. Um, yeah. I mean, I go back and forth of being like excited about. I mean, I am. I would want to. I don't have the budget that the frontier models and these larger companies do to like go after and get consumers. And I've also, I would say most of their solutions are half baked right now. If you've played with them, there's lots of documentation that stuff isn't working. Of course, that's going to get better. It doesn't change the fact that at some point, who is paying for this and what is the monetization model and how does that influence the product? If it is really engagement, like we've seen that happen with social media, who feels good about where we've gotten to? I don't. I shouldn't say other people may feel fine.
I do
There's
not.
also like the place of there's bias. I don't know if you I'll have to send it to you after this. There's a study that some folks did that used the exact same underlying LLM just with from a different context and got dramatically different answers. Your insurer is going to give you a different answer for what should be part of the care protocol than your hospital who's worried about liability, insurance was worried about cost. Doctors may have a different bias as well as the patient. And what I worry about is when the money behind these systems comes in, because sure, OpenAI has a patient facing, consumer facing model, but like a lot of their money, they also have enterprise customers that funnel that data. So even if it's not implicit in the monetization of health, that bias is now trained into the model, like because it's not necessarily always referencing the original literature and like the why piece, right? And so my big worry for healthcare, and this is not even consumer facing, is just how will we know? Right now, science and bias are separate because humans input, I mean, there's bias in science too, but how the knowledge collapse and for what incentive, those things are separate. Now, if they're used for the knowledge repository, it's going to be harder to disentangle that bias in all of our tools, the doctor facing ones, the ones that are running the machines, like in the hospital, as well as patient facing ones. So, like, I think that's sort of the risk at large and the thing that I worry about. I should also state, like, we have no sort of desire or ambition to be $1 billion unicorn tech company. Like I think if we do this right, we shouldn't be like it should be we should have lots of users
Right.
and we should be profitable and being able to support, be tech for good, like supporting people and not turning this into, I don't believe that healthcare should be a revenue capitalistic pursuit.
So Russell and I, we have a soft spot for the direct primary care movement. You're probably familiar with it.
Yeah.
Uh, and there are lots of things that we can articulate as to the value of that. As with anything, there's good and there's challenges.
Yep.
That's the reality of life. I would tell you, if I were a doctor, sometimes I wish I would have gone to medical school. It would have made life much more interesting. But if I were a doctor, and I started a DPC clinic,
You
I
would
would
give them
actually
this.
want to buy Insightful because I would want to create a more trusted relationship with my patient and
100%.
treat them like a consumer and then have them come to me with a more, I hate to say more thought out, but with their perspective on where they are, what their agenda is, what's important to them, and I can see that interact with it.
Yeah,
You probably have had
totally.
some buying signals along those lines, but I wouldn't be surprised if that is a target-rich market, for you because of this lack of trust, if you will, that big systems and their patient populations sometime on either side of the equation, they feel like.
Yeah. We're having those conversations, and I agree. I mean, the thing that DPC really solves, or even concierge, right, is this time component and
Yes,
this trust and relationship component. The system, not doctors, but the system has created this pressure points that make you say, like, I only have 15 minutes. I don't have time to read like whatever junk you found on the internet, right? Like, I don't think doctors believe that. They want their patients to be informed, but the constraints in which they're working in make that very hard. And so those models have removed one of those primary constraints. And you're right. We're hearing from those providers and clinicians. There's lots of other technical challenges that I'd say we are pursuing those in addition to consumer, partially because speed and EHR integration and all
Data
of
integration.
like the integrations and all the things. And so we went down that route. I would say none of that scares me. Like those are solvable problems. It's more an and rather than an or. The thing that we heard a couple times that gave me pause on this front was when we heard a couple times providers say, I really love this tool, but I want editorial access over it. This is too much, or I don't agree with this piece, or I don't offer that service. So, like, don't tell them that treatment option exists, like, and to me, that's like a non starter. The whole
that's a
point of
conflict.
this, yeah,
Yeah,
the whole point of this product is to root you in science and explore, like, no stone unturned is how I describe it. Not just what my insurance covers, but like, if it's life and death, like, I want to be able to move mountains. I want the opportunity to know that there's a mountain that I can move and get creative about it. And I don't know if the science is right. If your doctor doesn't agree with something, that seems like a great opportunity to develop a stronger relationship and trust and explain why this isn't applicable and, like, really lean in on the expertise. So
Yeah.
we got some early signals around this, like, editorial control, and we that felt like a core tenet and value of that we weren't really ready to budge on. But since then, we've been getting, and I think probably a lot thanks to some of the movement that's been happening on the consumer side of these models, we're having doctors sort of rethink that and are asking about how we can integrate into their practice and how they can pay for it and give it to their
hmm
patients. And
Yeah.
similarly, we hear that from advocacy groups, right? Like, I want to know what types of questions my people that with Parkinson's are asking so that I know what type of programming to do. Like, how do we help share, anonymous aggregated insights back, and in what context, with to again make this collaborative. There's so much support out there for patients. It's not just the doctor patient relationship, but the communities as well. And a lot of those communities fund the research, right? So then
yeah.
you can start getting pharma involved in, like, what information you're giving back.
Yeah. Yeah, I would hope that providers would look at this and say, be a little bit careful about going to ChatGPT. Be careful about going to Google. You can go there, but you might want to take a look at this because it's not the incentive structure here is different and the type of technology is different. And you're not going to be pushed in a way that's beyond scientific research if you use this tool. And I think that's important. I think that organizations should think about that as they work with their patients.
Well, Russell, I agree. What I'm going to say, and Erica, feel free to react to this. 350 million people, a million of those are physicians. Let's say there's another 5 million in the healthcare ecosystem, as nurses, as administrators, relatively educated. Let's call it 10 million. Let's call it 10 million. So 340 million people in the US, 330 million of them don't know, don't care, and are not really thinking about it. And they're like, oh crap, ChatGPT just told me I can figure out if I have the flu or not. And I'm going to go ask that, and I can't get into my doctor I can't get a primary care appointment. It's a real pain to go get an urgent care. And I don't really like going there because it's full of people and it's just busy and I'm going to ask this. And we've lost, and I feel like this is part of what you were talking about, Erica. We've lost that trusted relationship of you, the person that you trust doesn't always have to be right, but you've got to have an inclination to believe that they're coming from a position of wanting to help you and give you the best advice. And I would love to see a doctor say, look, I don't care what tool you use, but this tool is based on these things that's going to give you the best answer. And I would recommend it. These other things, feel free to use
Yeah.
it.
I mean,
Yeah,
you and me
there
both,
you go.
right? Like that solves that solves a big marketing problem
Yeah.
for us and a nice alternative to the thing that people are going to do regardless, right? So like I think that's the frustration and hurdle for medicine.
So, so Erica, we're coming close to the end of the time.
Mhm.
We didn't talk about this in the pre-show, so this is going to be, and you may say, hey, this doesn't impact us whatsoever. It's not even on my radar. But I'm going to ask the question anyway. That the feds, God love them, they dropped $50 billion on states. In reality, they dropped $10 billion on December 26th on states for rural health transformation. So every state got somewhere between 140 to 220, $230 million. Illinois got, I think, $193 million. Missouri got 212. Kansas got 240. You can all go look up the math and the numbers, et cetera. A big part of this, once again, whole separate pod discussion we're having on the impact, the value, the good and the bad of this. One of the mandates from CMS is to go increase access and to drive innovation to rural and really put more things in rural communities at their fingertips, almost akin to what you're building with Insightful. Have y'all talked about how this may be an accelerant or an impact, or is it just too amorphous for what you're doing today and how you would lean into it?
It would love to. I don't know how. So if any of your listeners are like,
Shout out to the
I'm an
community.
expert in rural, or I work there, or I'm in here in some way and want to facilitate an intro or a trial, like we are game, right? We had this actual conversation, like why the US even? Like we're based here, but certainly there are other places that are in worse shape than us that have less regulations and would clamor for something. It's a similar problem. It's like,
Yeah.
great, I'll go to India, but I don't know anybody there. Like facilitated, not anybody in medicine that can help, right? So this is the challenge of being at the stage that we're at and being sort of bootstrapped. We focused a lot on building an excellent product and it relied on word of mouth. And now we can rely on your audience as well of like, do you want to help? Like we really just want to help make the problem better and get people better care. And we're flexible on how to deploy that and where.
So I would say shout out to the community. If you're building in the digital health space and you are focused on rural health, have a thought, reach out to Erica. Erica, as you were saying that, Russell, you may have thought the same thing. There's a doc I feel like we really just need to introduce you to. I think y'all would have a fascinating conversation.
Love it.
All right, we're going to bring this to a close. I feel
Okay.
like, Russell, we could pull this thread for hours around consumer access, trust, transparency. We didn't even really talk about, which is a shame, the caregiver aspect,
Yeah.
because I think
It's
that's a
huge. Hmm.
huge impact, but almost lives in the shadows, no pun intended. But Erica, I would ask, let's say tomorrow Insightful is the biggest, best thing ever. You've accomplished everything you want to accomplish. You transition out, and then someone comes and gives you $10 million, and they say, whatever you want to build next, go forth and conquer. If it's not Insightful, what's the next thing you would tackle?
I can't even answer that question. I haven't thought about anything other than it. I mean, I would probably try to fund access for this, which is a cop out. Not that I'm going to lose your audience now. Not that Mark Cuban needs any more money, but I am fascinated by the experiments that he's been running on cost plus wellness, not even the drug side, the insurance direct side. And so if we're sticking within healthcare, I'm putting money in that. Like anything that drives more transparency, choice, personalization, and control is a win. And so I want to keep poking holes at that and in those problem spaces. And I'd probably give it to another founder, not myself. Just for like, if we really get that place, we got a lot to do. And we have lots of plans on how to, like I said, right now we share a lot of information, but the real, and this ties back to some of my advocacy roots at change.org, is like information is only as powerful as it results in an action and a change and a response. So there's a lot more to do to think about how to build tools that are effective at doing that rather than just educating. I say just, I mean, education is a huge component of it, but yeah, sorry, that's a non-answer to your
No,
question. Can't
hey,
even.
it's not a non-answer, and I appreciate it. I would just say to our audience, this has been a fantastic conversation. Please reach out to Erica, especially if you're in the rural health space. Take a look at Insightful. As Russell mentioned, he's played with it. Highly encourage, go interact with it. Consumers having a moment. We're all consumers of healthcare, and this in any form or fashion is going to be meaningful to you. And Erica, one final ask. You can be non-committal about this, but we would love to come back to you in a year from now and talk about what's changed, where things are, because I feel like there's going to be so much that happens over the next 12 months in this space.
Yeah, 100%. I love it. I hope I have even more data
Yeah.
and stories to share. We get them semi regularly. I mean, I understand people don't want to, being sick is sort of seen as a defect. So you don't want to necessarily share all the ways we can help, but it's why we get out of bed every day. And hearing those stories and knowing that what we did really made a difference. So yeah, please reach out. You can reach out to me on LinkedIn. I'm also hello at
Yeah.
insightfulmed.com. So yeah,
Yeah.
you can, that's an easy one to reach out for as well. And again, if you feel free to try it, connections, contributions, criticism, like it's all fair game. We are not precious about what we're building. Humility is a huge, I think, underrated value within being a founder. And that's where we learn the most. So yeah, I welcome any and all conversations.
Well, I couldn't think of a better way to close out our session. Thank you, Erica, for the time. Thank you to all of our listeners. This has been a wonderful conversation on the Counterweight.
Thank you.
Thanks for the invite.
Thank you for listening to The Counterweight. We are excited to bring new episodes out, and we are incredibly grateful to our guests and our listeners. We are committed to telling stories of those building and engaging at the intersection of artificial intelligence and healthcare. Let us know what you think by commenting on the episodes. As always, you can find us on Apple Podcasts, Spotify, YouTube, LinkedIn. Subscribe, like, and follow, and we look forward to joining you again next week for another episode of The Counterweight.